Afternoon, everyone, and thank you for being such an excellent audience. Thank you, Dr. Tinku, for a very engaging talk and making my talk easy because OCT is eventually the backbone of diagnosing all the macular pathologies. Sorry, it's not starting. Yeah. So macula is why this topic, because macula is the key to visual outcome after cataract surgery. It plays the most crucial role no matter how advanced we become in the form of machinery, IOLs or technique. If the macula is not supported, the patient's visual outcome will not be very good. Also, the choice of intraocular lens would largely depend upon the macular health. If the macula is already compromised, we do not recommend going ahead with a trifocal lens or even in some cases any EDOF lenses. So coming to the very basic, how to detect a macular pathology. And there we have our very own old age-defined 90-day examination, which will tell us if macula is healthy or not, and an indirect ophthalmoscopy to see the overall health of the retina. Look for very subtle signs, a dull FR. The FR is not looking very nice, the foveal reflex, an unusual pigmentation, a different coloration, a smallest of retinal hemorrhage, an unusual sheen over the macula, any atrophic patch or a scar that you see, do not ignore it. And the crux of the matter, consider a macular pathology if the vision loss is disproportionate to the density of the cataract. So for example, there's a grade 2 NS, but the best corrected visual acuity is only finger counting 1 meters. Just think because there has to be something else. And of course, as Dr. Tinku mentioned, OCT is eventually the key for diagnosing of all macular diseases. Go ahead with an OCT with the slightest of doubt. Coming to the most common condition that we all see in our practice, diabetic macular edema, because of course in India, diabetes is like rising really much. And in all the patients in diabetics, the cataract is also seen more frequently and earlier. So whenever you have a patient of diabetes with cataract with more than 5 years of history, look more intently for signs of diabetic retinopathy, as this DME is easily missed in early stages. Look for any sorts of microaneurysms. Hard exudates are still easily seen, but subtle, small edemas you may still miss. Go for an OCT, preferably. And the OCT, you will see, if the OCT is normal, well and good, you can go ahead with the surgery. But in case it's not normal, it might show a DME or a macular thinning. Either ways, you have to prognosticate the patient. It may just show signs of photoreceptor damage as in sign of ischemia. So something like this, if you get on the OCT, you see macular edema, you see hard exudate, don't just rush into cataract surgery because this is what is going to modify your plan of action. Because here you will have, this will affect the post-cataract visual outcomes. This will require treatment before or adjacent to the cataract surgery. So either in the form of anti-VEGF injections or steroid injections in collaboration with the cataract surgery, and also you have to counsel the patient that post-op also the patient will require more treatment. Starting NSAID eye drops pre-surgery is very important, even if you have slight amount of edema. And sometimes focal laser is also helpful if you find very nice focal leaks before doing a cataract surgery. It's very important to know that a case of DME missed pre-op may actually increase extensively post-surgery, leading to no gain or even fall in vision. So a fundus like this, where you don't see much hard exudate or hemorrhages, there is a slight front on the disc if you can make out, and the OCT is showing a slight elevation on the nasal side. Now this kind of a patient after cataract surgery, the traction might suddenly increase, the macula might go off, and the patient will lose vision. Coming to the second important topic, old vascular occlusions. Why old? Because the new ones are anyway glaring into your face. You see a lot of retinal hemorrhages and specific signs. But the old ones you definitely will miss. So look for signs of pale disc, pigmentary changes, any single retinal hemorrhage, occluded vessels, and of course collateral formation. So this patient came to us with a vision of 636. Cataract was definitely there, but if you see in the inferior quadrant here, you see some collateral formation. Did an OCT, and here we have inferior area CME. At the center also there is the CME. Now this patient, if I had rushed directly into cataract surgery, would not have gained much vision. So again, in a patient of vascular occlusion, the patient may show a macular thinning or an edema, depending upon whether there's ischemia and how much it is. And both of these will limit the visual recovery after cataract surgery. So it's important both for management as well as prognostication of the patient. And if there's a CME, do treat the CME before or along with cataract surgery. Coming to the third disease, AMD, because cataract and AMD both are age-related, we are going to have a lot of patients who have both. So when it comes to dry AMD, the diagnosis is very much clinical. You see those yellow drusen's lying on the retina, and you know what it is. Problem occurs when there's a wet AMD. So with wet AMD, many times you may not find hemorrhages all the time, and there could just be a slight amount of exudation. So this patient came to me with finger counting 2 meters, history of 6-8 months of vision loss, and there were not much hemorrhages on the fovea, but I could see some exudation. Going for an OCT, we saw a large subfoveal CNVM with a lot of edema, and of course, this patient is not going to gain vision after cataract surgery, no matter what I do. So you start the treatment. It's important that you tell the patient it's going to be a chronic treatment pattern, and the patient is going to require injections later on also. And how much vision improvement there's going to be, we don't know. ERM is a very common disease, may not require treatment at all the points, but this is also age-related. Look for a grayish, yellowish membrane over the macula. The discoloration is the key point. And the second thing is you might find the vessels being pulled or straightened. So these two signs will give you the indication. And if there's an extensive ERM, you have to go for a combined surgery, involve a retina colleague, and only then, because the cataract may not help. Macular hole is very much visible clinically, whether it is full thickness or lamellar hole or it requires treatment. Again, if it requires surgery, consult a retina person, and a combined surgery is the better approach. CSR, although not very well seen in older patients, it's more of a young patient disease, but whenever you see a CSR or an NSD in an older patient, try to look for a CNVM because that might be hidden somewhere. So if that is the case, you have to treat the CNVM as I told before. Very important topic, a MACTEL or a JFT, because here you will see an absolutely silent fundus. You will not see much, maybe here one or small reddish lesions or small patch of black pigmentation. But these patients, once you do an OCT, you will find a lot of findings. You might find loss of ISOS junction, you will find an ileum drape or a foveal thinning. And here you have to tell the patient, because you do a cataract surgery, but the patient may still lose vision eventually because it's a progressive disease and may form a CNVM later on. Coming to some rare macular pathologies, photic injury, a history, you can ask, old trauma, again, you don't know, but subtle signs like a pigmentary change at the macula will be the giveaway. So, and again, suspect all these, and another cause if vision loss is just not proportionate to the cataract. Cataract surgery has to be done, but this is basically for prognostication, because only when you tell the patient and you keep the expectation low, the patient will thank you for the surgery, otherwise you're going to be in trouble. So to conclude, a thorough macular evaluation is essential before cataract surgery. OCT is the gold standard for diagnosis. Identifying macular pathologies ensures better patient expectations and outcome. And even a perfectly done cataract surgery may fail if macula is not supportive. Thank you very much for your time.
Thank you, Dr. Anisha. So any questions, I invite you.
So Dr. Anisha, you mentioned that we should start NSAID before the surgery. How long before the surgery, and what are the indications? Where all would you start before the surgery?
Sir, for a diabetic patient, it's always better to start if the patient has any form of retinopathy, and even if the macula is dry, about preferably 2 weeks, but if not, you don't have 2 weeks, at least a week before, you start some NSAID prior to surgery, because this has shown to reduce the incidence of post-op CME, because even if the macula is dry pre-op, in these patients, post-op CMEs are very much known, even if the surgery has been uneventful. And one, if the macula is dry, and second, if there is very slight amount of extra macular edema somewhere or very little cystoid spaces, you can start NSAIDs, because that is going to reduce the chances of the increase in CME. Of course, if there's a gross CME, you have to treat with either a steroid injection or an anti-VEGF injection.
I mean, a patient without any diabetic retinopathy.
Still, you should, because studies have shown that the chances of post-op CME developing later on after cataract surgery is reduced with starting NSAIDs pre-op.
And what about the post-op NSAID? What is the guidelines on that?
Post-op, again, it should be given. I prefer to give it for at least 6 weeks, although we are also giving post-op steroids to these patients. But 6 weeks, yes, I definitely give. And because if the CME has to develop, it's going to develop in those 6 weeks' time.
Okay. Thank you.
Hello, doctor. I want to ask you, if we do laser photocoagulation for diabetic retinopathy or for venous occlusion, then after how many times we can plan for cataract surgery?
Ma'am, you mean to see the peripheral PRP and sectoral
Yes,
PRP?
yes.
It should, because all the lasers, they normally take 6 weeks to 12 weeks for whatever, because if you're doing a laser, there has to be a neovascularization, a proliferative disease. So we need to let it work. It takes about 3 months for the NVs to ablate. If the patient can wait, that is the ideal time period to wait. Once the ideal is that you perform an FA after that to see that the NVs have regressed, because the purpose of doing all that is so that the bleeding doesn't occur post-cataract surgery. If the cataract is aligned with the laser, then do the laser, wait for some time, do a repeat FA, and then plan the cataract surgery.
You said that macular edema or macular thinning should be treated before cataract surgery. So edema, I understand. There are some cases where you do not find any other retinal disease but macular thinning. So in these cases, if you want to do cataract surgery, what treatment do you do in macular thinning?
There is no treatment for macular thinning, but you have to inform the patient. You have to give a guarded visual prognosis. That is very important, that your vision may not be as great after surgery. So if there are no more questions,